So as I walk up here, am I on? I have to say good morning first, but no, I'm good. What you see before you is an example of pride cometh before the fall. And if I had have just admitted to my family that I'm tired and I'm going to go in, I wouldn't have failed to make that last turn on the mountain and do this lovely spiral fracture to my left femur. So with that, I have prepared a PowerPoint, but it's going to be more as a reference to you, and I've put in the very end of it 10 references that if you would check it and make sure that you've read these 10 references, I think to really optimally position yourself to be ready for what's, I think, coming at us. These are studies and reports that you're going to want to be aware of and allow them to influence your thinking. So I'm going to stand until I can't. I'm so excited to be here and wearing a dress for the first time since I've done this. Anyway, so today I want to talk to you about information technology, but I also want to acknowledge that information technology is not sufficient by itself to make a winning organization that beats all of its competitors. The other legs of the stool, as you all know, are your workforce and having a crackerjack world-class professional workforce and the world-class leadership and management. Information technology is an enabling tool. An important enabling tool, in my case, would be what we're going into. It's a critical enabling tool. So kind of taking off of the message that Bob Fosse left us with last evening in our opening session, in which he talked about we're at an inflection point. I so agree with that. And I see it as a very positive opportunity, a precedent setting. And so just to talk about why we've got this new window of opportunity that we've never had before. And it comes around the fact that we're doing this massive transformation of how we pay for healthcare in this country. We're in the early stages, early days, but it's coming as relentless as a freight train. And it is creating opportunities for partnering with post-acute care providers, and I want to make the case for specifically within the home-based providers that healthcare, home health stands to be the dominant player in this scenario. We see it. I have the honor of being part of the board for a health system in the greater LA area. And so I get to see how this dynamic plays out in the healthcare system. And in this last year, the awareness of the competitive pressures. Now, LA is a competitive market, right? But in 2016, we had precedent-setting record losses straight across our country, from one coast to the other, in our largest and most prestigious healthcare systems. And it is around trying to make this turn of that they're going to be judged on their quality of their care. It is permeating everything about how they do what they do. And increasingly, as we hit these alternative payment models, the challenge is that increasing percentage for the healthcare systems, and then with MACRA and MIPS in the ambulatory side of it for physicians, that how we deliver quality and the cost for what we deliver that care is how we're going to get paid. So you see it in this flood of reports coming forward from the healthcare consulting companies, from the American Hospital Association, how to build, the imperative of building post-acute care partnerships, how to build them, how to evaluate, and then select those that are absolutely the best. So, hearing some of the speakers yesterday talk about becoming a lean and mean machine, that's absolutely imperative, because they'll be picking who in their community is going to be the least cost but the highest quality. So listening to some of the comments made here, you know, the community, the home, it's such an important part of what we do in our home health. Our providers live in the communities in which they take care of our clients and our patients. And that is another strategic advantage that I think it's important for us to recognize, because when we talk about understanding what goes into health, we have to know that that's part of what gets embedded in the community. And just to, let's see, I don't want to go, let me just stay on this. So if we want to fit in with where the evidence says and where the health policy is saying healthcare must be, we know that we want our clients, our patients, to participate in their care. We want them to own that, to be active participants, and we want them to be happy with their care, and we want what we do to be something that's based on the evidence that's appropriate for that individual. And when we think about communities, you know, it's as basic as, do you have sidewalks? Do you have walking paths? Is it encouraging of exercise? Is it a community that you have to put rubber bands on your pants before you go into the house because you don't want things coming up your leg? So understanding our clinicians in terms of getting care that's appropriate and for that individual that will position us for the best outcomes, home health has a strategic advantage over any of the other models that you can see from telephonic care navigators that don't live in the dirt of the folks that they're trying to help. I'm going to bring this forward as a reference. I think it's important for you to know about it. It's just a recently published report. It was done by the formerly called Institute of Medicine, now called the National Academy of Medicine, in which it said our go-forward healthcare system has to have these 4 pillars. And so the commitment to continue to pay for value, quality, costs, that we have people participating in their care, being partners of their care, decisions made with including them, that we do it in the context of communities, and that we connect our care across settings so that it isn't about one being more important than the other, but it is a coordination of care. So what is it bringing at home for us? And if we look at the activating of communities, health determinants, it's all about where you live and what's the context for a healthy lifestyle or a harmful lifestyle. And these percentages are what each have been designated as contributing to wellness or to illness. Understanding that about your own communities and including that as you do your plans of care. The connecting care, we all know that that's about care coordination, having a multidisciplinary team that goes across settings, having a longitudinal shared care plan. But importantly, what they emphasize is this cannot optimally happen without having the underlying infrastructure of technology to make that data exchange happen. Also, that the ideal position, I just have to make these cases for home health in case if there's any doubt, that you know, not to be discouraged that there may be competitors, that, you know, what Marcus was just talking about, the complementariness of supporting individuals to get engaged in their care. That structurally, when individuals need health care, that this is this is where the sweet spot of home health will be. Is it's recognized in one of my most favorite researchers' work, Mary Naylor from the University of Pennsylvania. The Alliance, which is a part of this organization and the Go Forward newer, broader organizations, commissioned the research from Avalar. They did a cost comparison across all the post-acute care providers. So the hard data is in. It shows the business case. It's part of the recommendation that the American Hospital Association and Premier have done, that when you compare, they've got the same data and they're saying, check out your home health care providers. And then this last point is the CEO that I work with for the hospital board, who was talking to you about their own bundled care experiences. And where they previously had discharged to the skilled, they changed that to get better cost efficiencies, to to home health. And they realized tremendous savings. And he looked at me and he said, who knew that home health could deliver that? So I just thought I'd share that experience with you. So alternative payment models, just to make sure they're anything. It's not about the Affordable Care Act and accountable care organizations, which people say, well, that's all going to go away. These models are not going away. They're here to stay with us, and they are anything that is made up of carrying financial responsibility for a patient population, for an episode of care that goes 30, 60, 90 days, and all the costs that are associated. And these are the things that are driving the imperative to have partnerships that go out into that community that they can rely on and work very closely with. They get reimbursed based on that end of episode outcome and what the costs are to deliver that care. They can get positively reimbursed or they can get negatively reimbursed. And so healthcare organizations are struggling with this. This is part of why we see the statistics of what the financial outcomes of 2016 have been for our very large and sometimes not large, sometimes they're academic healthcare systems. The important thing in my going into the importance of information technology has to do with it. It means, just as some of the other speakers are talking about, that we have to be able to do analytics. And they can't be looking in the rearview mirror analytics. They've got to be in real time. We've got to know what we're doing and how well we're doing right now for our own internal analysis as well as to our partners. So it's got to be with the ability to bring together our clinical and our financial data so that we know what quality of care we're giving and what is costing us to giving. If we don't have that ability to do that today, there are a number of options that we can have. You heard our first speaker talk about this is an outsource option. There are tons of companies that are doing this because everybody needs to do this. You can also look as your EHR as a partner to be able to build that capability so you can do it in-house. This little chart is used widely and to make the case of this is here to stay. It's not going away. It's billions and billions of dollars, so it doesn't matter who's in the White House. We're going to be making this change. And this is from Sylvia Burwell, which was the previous director of CMS, saying that here's where we are in 2016, but this is where we're going. And it will increase from the projection here of 50% will be involved with the alternative payment models by 2018 and going to 70 and 80% as we go into 2020 and 2022. So learning how to give care, learning how to be part of partnership, that's the challenge. And this is, if you haven't seen this, this is work that comes from your very own leadership and the Alliance in partnership with the IOM and pulling together this Natural Research Council. It was published by a number of the authors, some who are in this room, 2016. It gives the big, broad framework of what's the potential for home health in this brave new world. So I recommend it to you. You may want to use it in some of your own presentations in your own organization. Now, coming into specifically what we want to think about in terms of what we need our technology to be doing for us. First of all, I want to make the point that your technology needs to be using 21st century technologies. And those technologies means that you can be directly connected to the internet. Sounds like not such a big deal, but it is. And we have to have systems that allow us to have the patient and family participate. When I was asking some of my clinicians when I was previously working as the chief clinical officer at Gentiva, where are you capturing the patient's story? They looked at me and said, well, you tell us where, if I was even to think about asking that, where would I document that? And sure enough, I went and looked at that, of our old system, which we replaced, and there was no reflection of patient participation, patient story. But I submit to you, you cannot get an appropriate plan of care without taking into account the uniqueness of that individual. Nor can you go up against bundled plans that you're a partner in that have a fairly rigid protocol without that data. So it's a critical component to this new world. And you also want the ability to append all of these other kind of extraneous things, especially when you're in communication with your providers. You want that to be part of the record. And the tools that we have now available to us for encryption and to meet the HIPAA and the safeties make these issues non-issues. The enabling of team care sounds like not a big deal to say shared views of the care plan and documentation, that everybody is on the same page literally. They're all in that patient's record as they're doing their team conference from their very different geographic points of where they're doing this conference call to evaluate from all of their different discipline perspectives as well as your partners. But it means that you've got to have real-time access into that patient record, and you've got to have connectivity from wherever you are to the internet to do that. These other points, no duplicate data entry. It means fundamentally that the data that's going into your system is generated from the work that we do. That it isn't, God help us, that we take data from one system and manually key it into another, or we say, oh, we don't have this data, so we're going to key this in to generate the reports. That's not lean and mean. That's duplicate work that will cause you to be more costly than those that don't have this added work. We need to be able to aggregate our clinical data. We need to be able to store it, retrieve it, and report on it. Clinicians seeing their own outcome, I've seen that as being the most powerful tool for change. That clinicians who thought they were absolutely stellar, couldn't be any better than me, you show them their outcome data, they may be devastated, but boy, they get committed to improving. And so it's just an important step in the ability of your systems to support that. Now, what does it mean for functionality that we need to have to be good partners with other post-acute, ambulatory, and acute care? Well, fundamentally, you need to be able to send and receive data specific to the patients that you're sharing, that you've got a legal and financial obligation to each other about. That you can track and report on those shared patients so that you can do population health within your own system, and that you can generate the needed quality reports and the costs so on those patients in aggregate for the defined time periods that they are being held accountable for. Standards, this starts getting into technical, but if there are folks here, it means you got to have that as part of your underlying. And then that the clinical, financial, and your resources, the resources that you use, again, have to be generated from the work processes rather than from external work. And it goes into the last point of that's minimizing the imposition on your own staff and your own clinicians. I doubt if very many of us are there today, but it's why working with your vendor as a partner to get on this journey, these are early days and you have time. So use that time to say, I know where I want to go, and have a really strong, trusting, good partnership, working relationship with your own EHR vendor. Architecture matters, and that's that point. You've got to be using 21st century technology. We live in a world of the Internet of Things, of some of the things that Marcus was talking about. We used to think that our elderly patients wouldn't use technology, and that is definitely debunked. We have got a fairly empowered elderly that have found that these are tools that help them with their social isolation, building their communities, looking up stuff, being able to report their own blood pressures, their own home values to their providers. And this cartoonish character over here is meant to really reflect the fact that we've got so many sensing devices now that have been built and that people are using with the expectation that they can send that to their provider, they can update their patient record, they can have that as part of their record that influences their care. And it speaks to the point of all my little smartphones over here, where I bring up the point that this has happened in a relatively short period of time. The iPhone was introduced into the United States in 2007. And in that interview, not even, a decade, we've had over 165,000, just for the iPhone, healthcare applications built. And by 2017, The Economist is reporting that those applications have been downloaded 1.7 billion times. So I want to come back up to the fellow, the cartoon. He represents an NHS endeavor in which they found that taking care of patients with chronic, specifically congestive heart failure, giving them just an old-fashioned laptop and letting them enter their data and send it, saved them thousands of dollars per episode of care. It was so cost-effective in their pilots that they decided they would automatically give a laptop to every patient admitted to their service. So sometimes it isn't about super-duper high-tech and the latest gizmo of this or that. It's just really being effective with what technology tools you have at your disposal. And then finally, I want to encourage us, because we've got such new, in the world of application programming interfaces, oftentimes referred to as APIs, that have come out of the woodwork because EHRs are black boxes that don't do all the things with the nimbleness that we need them to do, that we can use these tools to make FaceTime something that works for us, to do low-tech, really cost-effective teleconferencing in the home for our orthopedic patients, our wound care patients. So please think about those. And as the old wise owl says, it's not what you have that counts, it's what you do with what you have. And these are the references, and I just thank you so very much for this opportunity to talk to you.